que estar yo. Ahí está, voy sí. Ya ibas. Thank you.
You are welcome. Ahora, arriba, mira, espérame, regrésate ahí. Arriba donde dice terminar emisión, a la izquierda hay una flechita.
Ajá.
Ajá, ahí es correcto. Entonces solo pone copiar enlace. Ahí. Ajá, exacto. Y me lo mandas a WhatsApp para mandarlo a Telegram. A Telegram. No, sí, a Telegram. Para mandarlo a Telegram y a los invitados especiales.
Ok, listo. ¿Cómo estás? Quiero que me digan si el sonido se escucha, por favor.
En YouTube. Ok, ahorita.
Y en Facebook.
Ok, revisaré primero en YouTube. Ok, hey, estás en vivo. Son un éxito, Lisandro. Demasiado.
Eso.
Está cheque, ¿listo?
Ok.
En YouTube, y voy a ponerlo y lo voy a poner en YouTube para que me interrumpa. No, sos demasiado crack para eso.
Listo.
Y entonces yo te voy a revisar el ¿Sudaste? ¿Cómo están las glándulas sudoriparatorias?
Uy, sí, estoy, pero sudando, estoy taquicárdico igual que antes.
Sí, ay, así estaba ahí, yo estaba como tirando contigo en tanto.
Ok, voy a probar a hacer co-host. A ver, ahí está, ya, ok. Bueno, creo que estamos bien ya.
Oh, ya. ¿Dónde está el calor? It's going pretty good. We're just working on the tech side of things, which is not our specialty, but we're working on it. So this is the team. This is today's team. We have Lisandro Gravis. He's doing the magic in the tech side. Lisandro es de Santa Fesi. Estoy presente.
Mucho gusto. My English is kinda bad, so I prefer to speak in Spanish.
Que el español es pésimo. Entonces,
Sí.
terrible.
Creo que somos dos.
That inspired me, I don't know. And then we have our moderator of today. Her name is Breni Alexa Nolasco. Breni te presenta el doctor Luke Ceci. Para que lo conozcas.
Hi.
Un placer conocerte. So yeah, like I was mentioning, we're gonna do the translation. I think that so that we don't like prolong it so much, we're gonna do it via text, like the chat. So I'm basically gonna copy what you put, and I'm gonna put it in the chat. And on the program we're using, it's gonna be like scrolling. So that's what we're gonna do. And if you want to say something extra, I'll be like pendant of what you're saying, so I can like add. And if you want to do like a question, a live question, I'll probably just open up the mic and I'll do the question live. We don't actually have people in the Zoom because we've had too many issues with that in previous years. So we have them on YouTube Live and on Facebook Live. So we have our moderator. She's going to be like checking if there are any questions on those pages, and we'll be checking for answers to your questions. Sure. Yeah, we can do that. And like I said, I will text you whenever the moderator is done speaking, when she's like, okay, so now I present this person, he's gonna talk now, and I'll just be like, okay, go, so that we can. We've never done this before, so this is new. Like, hopefully we'll like, get the kinks worked out. But we're really excited to have you, and we're really thankful. I know it's kind of late over there.
I'm actually being in Paris for this.
Yeah.
Right,
Great, great. So chicos, dice el doctor que, bueno, básicamente hablamos de cómo va a ser lo que ya hemos hablado, pues lo de la traducción. Yo lo voy a estar pasando por el chat. Y las preguntas en vivo, yo voy a abrir el micrófono y las preguntas en vivo. Y Brenda, ya hemos pensado, nos ayudas con las preguntas en Facebook, YouTube. Y el chat de Telegram, ya que habilitamos el chat para preguntas ahí. Y dijo que está súper emocionado. Yo le dije que nunca hemos hecho eso, que estamos emocionados, pero dijo que ahorita está en París y son las 9 de la noche allá, pero que está listo para cualquier cosa.
Okay. ¿Me avisas cuando inicio?
Yo les voy a avisar. We're just gonna make sure all the tech stuff is set up, and then we'll let you know when Breni's gonna start talking. She's gonna introduce you, and then I'll just like let you know. Yeah. Lisandro,
Fíjate que me están diciendo ahí por redes y por WhatsApp todo esto. Pero bueno.
Oh. That's fine, está bien, no hay problema. Ahí lo contamos después. Bueno, cuando ustedes estén listos, si se escucha bien todo, entonces ya.
Sí se escucha bien, solo que algo porque que se escucha un poquito bajo, no sé si bien mejorar eso. Y si no, pues bueno, por igual, creo que se escucha bien.
Ok. Cuando querrás, Breni.
Ok, ya, voy a iniciar.
Dime un segundo. Me les aviso. Listo ya.
Ok. Hola, mucho gusto a todos. Soy Brain Nolasco, alumna del segundo año de la carrera de medicina. Soy parte del comité organizador de la 7ª jornada científica de VIIa. Es un placer pues poder invitarles el día de hoy, miércoles 17 de noviembre. Y hoy estaremos con 3 expositores que nos van a hablar sobre diversos temas como ser fundamentos de la hipertensión, diabetes y antibióticos. El enfoque pues queremos que sea o va a ser interactivo y por ende pues les pedimos pues estar pendientes en las preguntas y actividades interactivas que nos traen nuestros expositores a través del chat. El día de hoy pues iniciaremos el bloque 3 de conferencias y para eso nuestro primer expositor del día es el Dr. Lux Fesi, médico de primer año del Hospital Salford Royal de Manchester en el Reino Unido. Cosas importantes sobre lo que es la conferencia del día de hoy es que nos estará hablando acerca de los fundamentos de hipertensión. Esta ponencia pues va a ser en inglés, lo que estaremos pasando la transcripción en español de la ponencia a través del chat. Por favor, pues les solicitamos estar pendientes sobre las preguntas que se estarán haciendo y para ello pues se aperturará el micrófono y serán traducidas directamente. Al igual, si tienen alguna pregunta, al final de lo que es la conferencia se le estará leyendo. Quedan el doctor para que pueda iniciar.
Okay, thank you very much. Can I just ask you to enable screen sharing, please? Okay, so hello everyone. Welcome to my talk on hypertension. My name is Luke. As Bradley said, I'm one of the first year doctors at Salford Royal Hospital in Manchester in the UK. It's lovely to be here. I'll be delivering this lecture in English, but Joyce has kindly agreed to translate for me. So just to start out, to give you an idea of what we're doing, we're going to start by defining what we mean by hypertension. We're going to talk about what causes it, and we'll talk about how we diagnose it. We'll then move on to talking about why we actually treat it and what our treatment options are in terms of pharmacological, so medications, and non-pharmacological, so diet and lifestyle modifications. We'll also talk a bit about when to be cautious with medications and which side effects you should be watching out for. And then we're going to finish off with some interactive cases. All right. So starting off with a quick definition, we define hypertension as having an average blood pressure of greater than 140 over 90 millimeters of mercury. This value is fairly arbitrary. There's not a huge amount of reason behind it, and we're actually going to discuss later some evidence that supports having a lower threshold than that. As a rule, it's best to bear in mind that the top number, the systolic pressure, is the one we're fairly concerned about. The diastolic is rarely particularly relevant. In terms of how we diagnose it, hypertension is usually found incidentally, so maybe during a routine clinic appointment. A one-off measurement can raise a suspicion of hypertension, but to confirm the diagnosis, we really need to monitor blood pressure over a period of, just for example, 24 hours, either with an ambulatory device, so a cuff that goes around the arm with a machine that is attached to someone as they walk around, or with regular home blood pressure monitoring with a machine. Once hypertension is diagnosed, we ideally do a set of other tests. These would include a urine dip, an albumin to creatinine ratio, which is just analysis of the urine, which measures the leakiness, essentially, of the kidneys. And we use that to assess the severity of chronic kidney disease. We'd also want to do an ECG and a set of blood tests to evaluate the other cardiovascular risk factors. And all those tests are being done really to evaluate for end organ disease or target organ disease. And that's something we'll come on to talk about more later. If a patient is already on several medications and is being for the addition of another, as being assessed for the addition of another, then a lying and standing blood pressure can be done. This is because when a patient's on multiple antihypertensives, this can cause what we call a postural drop in blood pressure. So that's a drop in blood pressure when a patient stands up, and that can lead to syncope and falls. We have a few classes of blood pressure. I'm not going to talk too much about these because these, again, are fairly arbitrarily defined. These are the ones we use in the UK. There's no particular reason for them being at the intervals they're at. And those are the investigations that I mentioned earlier. Okay. So one of the most important questions really, especially in primary care, is who needs to be referred to go to a hospital to be assessed on the same day. So who's really ill? Patients with accelerated hypertension have to be referred to hospital urgently, and that is defined as having a blood pressure that's risen to over 180 over 120 plus one of two things: either papilloedema or retinal hemorrhage on fundoscopy. So papilloedema, that's the swelling and the edema around the optic disc that can be seen on fundoscopy, and retinal hemorrhage is obviously rupture of some of those blood vessels on the retina, or life-threatening signs, so symptoms indicating an acute damaging event to organs, such as new confusion, such as new heart failure, chest pain indicating damage to the heart, or an acute kidney injury. Sorry, that's what AKI stands for. It's acute kidney injury. So for example, if there's a sudden decrease in urine output, you might worry that there's damage to the kidneys as a result of that very high blood pressure. If you do these tests and the blood pressure is high, it's over 180 over 120, but you don't have those features of accelerated hypertension, so you don't have the pachyedema, you don't have the life-threatening signs, then you'd want to do tests for end organ damage, like the ones you mentioned earlier, but you might not have to refer that person that very same day to the hospital. Okay. Now I'm just going to talk a little bit about the etiology, so the cause of hypertension. In 95% of cases, there is no one real clear identifiable cause as to why someone has hypertension. Despite being very well studied, we still don't really know how it starts, but there are actually several very well established risk factors. There are also many theories as to why people develop high blood pressure, but if I went into those, that would be an hour lecture on its own. In terms of our well-established risk factors, which do play into that somewhat, obesity, alcohol, insulin resistance, so that's type 2 diabetes really, or pre-diabetes, general aging, so as people age, their blood vessels get calcified, they become stiffer and less elastic. Stress and high salt intake are all things that we know play into hypertension and can exacerbate it. It's also worth mentioning that there are, I'd say, 3 important endocrine, so hormonal conditions that can lead to hypertension, or of which hypertension is a symptom. I'm going to briefly cover them, in part because they are important causes of hypertension, and in part because they actually do come up in your medical school exams. These are Conn's syndrome, Cushing's syndrome, and a pheochromocytoma. And we'll just go over those in the next slide. Yeah, so we'll start with Conn's syndrome. So Conn's syndrome refers to increased secretion of the hormone aldosterone. That can either be due to hyperplasia of the adrenal glands, so growth of the tissue, or it can be due to a tumor that can be malignant or benign, usually benign. The effect of aldosterone, or the key effect of aldosterone, is to cause reabsorption of sodium in the kidneys, specifically in the distal convoluted tubule, and potassium excretion. When this happens, when the sodium is reabsorbed, that creates a concentration gradient along which you get osmosis of water. So water moves out of the tubule of the kidney and into the blood. And it's a good rule of thumb for endocrine conditions that when you have sodium moving, water moves with it. So water follows sodium. Now this water retention increases the blood volume, which increases the blood pressure. Patients can also experience some polyuria. That's not actually linked to the change in movement of water or sodium. That's because it disrupts the function of antidiuretic hormone. And so they get diuresis, they urinate a lot, and they can also get headaches. The condition is sometimes hereditary, but most of the time it's just a random mutation. And then treatment is either with surgery, or it can be with aldosterone antagonists, so like spironolactone, which we will actually mention later on in the talk. And it depends very much on the cause as to which of those you would do. Okay, so the next is Cushing's syndrome. So this is caused by excess cortisol. The most common cause of this is actually the medications that we in hospital give to people. So it's usually something that doctors do to patients. After that, second CTH, which causes a release of cortisol from the adrenals and causes the Cushing syndrome. It's actually, in terms of its relation to hypertension, very similar to Conn's, because cortisol also causes sodium retention. So sodium moves into the blood from the tubule of the kidney, it pulls water with it, that increases the blood volume, that increases the blood pressure, and that leads to hypertension. And the treatment of that is more complex. We're not going to get into that right now. Sometimes it's treated medically and sometimes it's treated surgically, and that will depend totally on what has caused it. And there's a wide variety of causes. Okay. The last one to know about is something called a pheochromocytoma, and it is a really quite rare adrenal tumor that can cause intermittent hypertension by secreting catecholamines. That's a group of chemicals that include adrenaline, noradrenaline, dopamine. You may have heard them referred to as epinephrine and norepinephrine. And these chemicals all lead to vasoconstrictions. They lead to contraction of the smooth muscle around blood vessels, and the vessels narrow, which increases the blood pressure. These tumors are very rare, but they do come up in exams, and they are something that requires urgent treatment if they do occur. They cause paroxysmal, so episodes of palpitations, of fast heart rate, of sweating, of hypertension, and these are all direct effects of the catecholamines that are released from the tumor. We treat them with an alpha blocker, and this reduces the blood pressure, a beta blocker, which reduces the fast heart rate, and then with surgery to remove the tumor. And that honestly is everything you need to know about pheochromocytomas. You probably shouldn't be learning anymore. They really are quite rare. Okay, in terms of the epidemiology of hypertension, just coming back to that, it is very, very common worldwide. It's a disease that affects a huge number of people all over the world. The prevalence varies by ethnicity and region. The WHO reports that it's highest in Africa and lowest in the Americas, but is substantial in both. If we look at those statistics, that averages out at around a quarter of people have hypertension, which is billions of people. Hypertension is following the trend of other cardiovascular and metabolic diseases by increasing at quite a sharp rate. So in 1975, it affected about 594 million people, but 40 years later, in 2015, it's affected 1.13 billion. So it is increasing at a very sharp rate. So now we come on to one of the most important parts of the talk, which is why do we actually treat hypertension? Because it's asymptomatic. It won't cause symptoms for the vast majority of patients. So why do we treat it? The answer is that chronically high blood pressure, leads to dysfunction of the endothelium. So that's the inner layer of blood vessels that has a huge role in regulating their function, and it leads to the production of inflammatory molecules. This actually leads to the vessels becoming stiffer and narrower, which impairs the blood supply to key organs and can lead to complications. And the most classic organs affected by that are the kidneys, so you get renal injury, the brain, so it can lead to changes in the artery, which can then make strokes more likely. Acute coronary syndromes, for anyone who's not come across that before, that's myocardial infarctions and unstable angina are the conditions that are referred to as acute coronary syndromes, and retinopathy, so damage to the blood vessels supplying the retina, and so impaired vision ultimately. And we treat this because we have very strong evidence that actually controlling blood pressure aggressively reduces the incidence of these complications. So just to briefly go over the evidence, we're going to start with a large meta-analysis of over 600,000 patients that was published in The Lancet. And it demonstrated that for every 10 millimeters of mercury reduction in the systolic blood pressure, there is a significant percentage decrease in the major complications and overall mortality associated with hypertension. So if we just look through. So that's between a fifth and a quarter reduction in serious complications like a cardiovascular disease event, like a stroke, like heart failure, and over a 10% reduction in mortality. So these interventions do make a big difference. Interestingly, the analysis didn't actually show a benefit on the risk of kidney injury with aggressive treatments of hypertension, and we'll actually discuss why it looks like that is in a moment. And the other trial, I just want to briefly mention, just to really give you a background as to why we actually treat this condition, is the SPRINT trial. It was a randomized control trial where over 9,000 patients were randomized to blood pressure control with a target of either less than 120 or less than 140 systolic blood pressure. And the less than 120 group actually significantly reduced the risk of acute cardiac events, so like myocardial infarction, as well as actually the risk of death per year. This is really quite interesting because actually we, certainly in the United Kingdom and often worldwide, the target for hypertension is to keep blood pressure below 140. But actually this trial showed that going below 120 does have added benefit. So there is point in going beyond where we currently go. Part of the explanation for why we don't do that is the higher rate of complications that we found in this trial. So that's things like electrolyte abnormalities, that's syncope, acute kidney injury. And that actually explains the findings of the previous meta-analysis. So if acute kidney injury is a side effect of aggressive treatment with antihypertensive drugs, it would explain why actually the meta-analysis found no overall benefit, because although it probably prevents some damage to the kidney from hypertension, it also causes some from overtreatment. Okay. Now, I realize this is a complex looking diagram. Don't worry, we won't spend too long on it. But if you're trying to understand hypertension, the key system you really need to understand is the renin-aldosterone-angiotensin system. So in the system, the hormone angiotensin is made by the liver, just over here, and is converted to angiotensin 1 by renin, which is found in the kidney. This angiotensin 1 is then converted to angiotensin 2 by ACE, so that's angiotensin converting enzyme. That's found mostly in the lungs and a little bit in the kidney as well. Once angiotensin 2 is formed, that is the major effector of the RUS, as I'll be referring to it, the RUS system. And that's got quite a few effects. You can see that activates the sympathetic nervous system. It causes directly reabsorption of sodium from the kidneys. And as we said before, water follows sodium, so that retains sodium retains water, so increases the blood volume by retaining water. There's also secretion of aldosterone from the kidneys here, which actually then feeds back into this effect because it has that same effect of reabsorbing sodium. So there's a bit of a double hit there. There's a direct effect of vasoconstriction over here. So this acts on the smooth muscle surrounding arteries. And finally, it increases the secretion of antidiuretic hormone, which again causes water reabsorption from the kidneys into the blood, increases blood volume, increases blood pressure. So all of these effects together, mediated by angiotensin 2, work to increase blood pressure. Just to simplify that a bit, we can summarize the actions of angiotensin 2 as the follows. So the stimulation of release of adrenaline from the adrenal glands leads to vasoconstriction. There is also direct vasoconstriction as an effect of angiotensin 2. There is then an effect on the adrenal, which causes the release of aldosterone, which causes sodium absorption. As we said, sodium absorption is water absorption. And then there is the direct effect of angiotensin 2 on the kidney, which causes sodium resorption. So there's a bit of a pattern here, really, isn't there? It has a direct and an indirect effect on these two major things. So if we actually boil that diagram down, this complex system does one of two things. It either causes vasoconstriction or it causes sodium retention. And this is important to note because this helps us make sense of why the treatments that we use for hypertension work. So now we're going to get into the pharmacological, so the medicinal treatment of hypertension. And I've divided these treatments by the organ which they target. So first we have the calcium channel blockers and the alpha blockers. Both of these target blood vessels. Then we have the diuretics, angiotensin converting enzyme inhibitors. That's what that stands for. We have the angiotensin receptor blockers and the angiotensin receptor blocker / neprilysin inhibitors. That's a fairly new class we're talking about for the kidneys. And then we have just the one class, beta blockers, which play a more minor role in the treatment of hypertension. We'll talk a bit about why that is. As you can see here, and if we think about, again, the renin-angiotensin-aldosterone system, the two main components of that in terms of the effects of angiotensin 2 were the vasoconstrictions, the blood vessels, and the sodium retention to the kidneys. So it makes sense. The vast majority of our drugs act on the blood vessels and the kidneys. Starting with the blood vessels, we're going to talk about calcium channel blockers first. So calcium channel blockers can be divided into dihydropyridines and non-dihydropyridines. This is based on their chemical structure. Dihydropyridines are the most important class when it comes to hypertension. And to remember them, they all end with idine or pidine. An example is amlodipine. That's a very commonly used one. They inhibit calcium channels in the smooth muscle that surrounds blood vessels. Inhibiting those calcium channels means that the smooth muscle cells can't depolarize as normal, so they relax, so the blood vessel dilates, and that reduces the pressure within them. Non-dihydropyridines are less relevant to hypertension, but for completeness, they tend to act on the heart rather than the blood vessels, have fairly minimal effect on the blood vessels. They reduce the actual force of contraction of the myocytes, so the cells within the heart responsible for the actual contraction. And so, to a degree, will reduce the pressure generated by each heartbeat. They can also act on the heart's atrioventricular node to reduce heart rate, which isn't particularly relevant to hypertension, but is relevant to some of the drug interactions that we're actually going to talk about later. These types of calcium channel blockers are not really used in hypertension because although they reduce the force of the heartbeat, they don't interact with the renin-angiotensin-aldosterone system. And so the mechanisms that are responsible for keeping blood pressure high will still work to keep the blood pressure high. So it doesn't really address the true cause. And then the last medication for blood vessels is alpha blockers. So these all end in osin. So an example we use very commonly in the UK is doxazosin. These directly inhibit alpha-1 receptors. So that's one of the adrenergic receptors, so receptors for adrenaline, noradrenaline. And these alpha blockers block those. And what you then get is the smooth muscle again around the blood vessel relaxing. Pardon me. And this is because of an absence of sympathetic stimulation, because adrenaline is the effector of the sympathetic nervous system, which is the fight or flight part of your nervous system. So if you block that influence on the blood vessels, then they'll relax and dilate. Okay. Moving on to the kidneys, we're going to start with the diuretics. So these are medications to excrete water from the body. That's what a diuretic means. So diuretics act to increase the flow of water through the kidneys. This water removes volume from the blood, which removes or lowers the pressure of blood by decreasing the volume. If we think back to the renin-angiotensin-aldosterone system, these diuretics actually act in the exact opposite way. So they tend to act in the kidneys. This is a thiazide and thiazide-like diuretics. And these act in the distal convoluted tubule of the kidney. Which is important, but the important is that they excrete sodium, and the water follows sodium, as we said before, so it removes water from the bloodstream. And if we remember back to the RAS, this is the exact opposite of how that works. So it's directly targeting that mechanism that's designed to bring the blood pressure up in order to bring it down. By contrast, we have these potassium-sparing diuretics, so they will end in -one, for example, spironolactone, which you mentioned earlier. These block the receptors for aldosterone, which, as you remember, was one of the ways that the renin-angiotensin system raises blood pressure because of sodium resorption. And so again, by blocking that, it leads to sodium excretion, which leads to water excretion, decreased pressure. So all the effects of aldosterone. Okay, ACE inhibitors. So ACE inhibitors all end in pril, for example, lisinopril, and are the most direct way of manipulating the RAAS to decrease blood pressure because they reduce production of angiotensin II. So they inhibit that enzyme that we talked about that turns angiotensin I to angiotensin II. It's found in the lungs and to a degree in the kidneys. With a reduced production of angiotensin II, there is less of the effects of angiotensin II. So there's less vasoconstriction, there's less sodium reabsorption, which leads to a lower blood pressure. The ARBs are very similar medications. So just to remind you, that's the angiotensin receptor blockers. They all end in sartan, e.g. losartan. They have very similar effects to the ACE inhibitors. The key difference is that ACE inhibitors can cause quite an irritating cough, as the enzyme that is inhibited, so ACE, angiotensin converting enzyme, is also responsible for breaking down a chemical called bradykinin. And when bradykinin accumulates, because it's not been broken down, it can cause quite an annoying dry cough, which does tend to bother patients. ARBs don't have this side effect because they allow the angiotensin converting enzyme to keep working and break down the bradykinin. So for patients who develop a cough, if they're taking an ACE inhibitor, we tend to just swap them over to an ARB instead. They have very similar cost and effectiveness. Previously, ACE inhibitors were favored because they were cheaper. Certainly in this country they were, but now actually they're very much level in that respect. And lastly, for medications affecting the kidney, we're just going to mention the combination angiotensin receptor blocker and neprilysin inhibitors. The only really mainstream one of these is its trade name is Entresto, and it's a combination of sacubitril, so that's the neprilysin inhibitor, and valsartan, that's the ARB. Neprilysin is an enzyme which breaks down certain chemicals that cause dilation of blood vessels. So by inhibiting this enzyme, that drug causes vasodilation, which reduces blood pressure. Particularly, these chemicals are bradykinin and certain natriuretic peptides, so peptides involved in the excretion of sodium, which I'm not going to go into too much, but it's just important to know that these act to reduce blood pressure and dilate blood vessels. And so by giving this enzymatic inhibitor to increase their concentration, this reduces blood pressure, sorry. And it's then combined with an ARB to produce a greater effect than either drug alone. Okay, and then finally, we are going to briefly mention the antihypertensives affecting the heart. So these are beta blockers. They end in a suffix -olol. An example is bisoprolol. So as previously mentioned, the heart is less of an important target in hypertension because it's less important in the regulation of normal blood pressure. Sounds like quite a strange thing to say, but beta blockers work similarly to the non-dihydropyridine calcium channel blockers that we mentioned earlier. So they reduce the force of contraction in the heart. They do this by blocking the adrenergic receptors, and that's got what's called a negative inotropic effect, so reduces the force of contractions. And it's the beta-1 receptors that those are targeting. That's the beta receptor that's specific for the heart. And yeah, they're not generally as useful for hypertension. They are sometimes used, but aren't hugely useful. But whilst we're talking about them, I thought I'd give you a useful tip for the naming system used for beta blockers. This certainly isn't something I knew at medical school, but is helpful figuring out what they do. If you put them in alphabetical order, all of the ones from A to M are what we would say are cardioselective. That means they will only, or to a degree, only affect the beta-1 receptors. So they'll only have their effects in the heart, and they won't trigger beta-2 receptors, which are generally found in the lungs. And so blockade of beta-2 receptors can lead to undesirable side effects like bronchoconstriction, which can be particularly dangerous, say, in asthmatics. Those beta blockers that are named N to Z are non-cardioselective, so they affect beta-1 and beta-2 receptors, so they have those other side effects as well. There are a few exceptions. These three beta blockers also are alpha blockers, and so have some special uses, and nebivolol doesn't follow this rule. But other than that, it's a good way, or it's how they're named, and so it's good to know that so that you can figure out a beta blocker's function just from its name. Okay, so I'm now going to take you through the NICE algorithm. That seems like a weird title. That's NICE, as in the National Institute for Clinical Excellence. That's the organization that sets the guidelines in the United Kingdom for doctors. This is just the one we use. Obviously, that will differ from country to country, but I'm going to use it as an example of how to think about treatment because it's a very well-evidenced model. In step one, we divide people into two categories. So we have these people on the left who are under 55, or they have type 2 diabetes, or they have chronic kidney disease and an ACR of over 30. I'll explain what that means in a second. And on the other side, we have people who are either over 55 or who are Black, so of African or Caribbean origin. ACR, I think I mentioned earlier, is the albumin-creatinine ratio. It is a marker of how leaky the kidneys have become in chronic kidney disease. A higher value indicates worse disease. And just to show you, this is how we classify chronic kidney disease. On the left, we have filtration rate of the kidneys, so how quickly, essentially, the blood moves through them. And on the top, we essentially have this albumin-creatinine ratio, which tells us how leaky they are. So an ACR of over 30 would put us in this severe category. So if their kidneys are damaged enough to be in this severe category, then we prefer to put them on the left-hand side of the algorithm, not the right. The reason for this divide is because we have evidence that shows that different medications work differently for people based on age and race. So ACE inhibitors and ARBs don't particularly work in people who are over 55 or of African or Caribbean origin. They work a little bit, but not as well as they could do or as other medications do. So for step one, for this left-hand side, we would offer either an ACE inhibitor or an angiotensin receptor blocker to group 1. And ideally a calcium channel blocker, or if that's unsuitable for whatever reason, a thiazide-like diuretic. So we covered those earlier. So those are the ones that increase sodium excretion in the distal convoluted tubule of the kidney and take water with them and reduce blood volume. Now, the reason that type 2 diabetes and chronic kidney disease patients are in this group is because ACE inhibitors and angiotensin receptor blockers have actually been shown in trials to be protective to the kidneys long term. Obviously, in chronic kidney disease, they already have damage to the kidneys, and type 2 diabetes, they're vulnerable to damage from the kidneys. So we like to give them those medications to try and help protect the kidneys moving forward. Now, if for whatever reason a Black patient can't have a calcium channel blocker or a thiazide-like diuretic and has to be started on an angiotensin receptor blocker or an ACE inhibitor, then we prefer to give the ARB over an ACE inhibitor because there's an increased risk of something called angioedema, which is a rare side effect of ACE inhibitors, which causes swelling of the face and throat, is usually just uncomfortable, but can occasionally be dangerous. So we prefer to start those patients on ARBs. Step 2 is just to add a drug from the other class, so from the opposite class. So for example, for group 1, we might have an ACE inhibitor plus a calcium channel blocker or a diuretic, and for group 2, we might end up with a calcium channel blocker and either an ARB or an ACE inhibitor. Step 3 is then to add all 3 of these, so an ACE inhibitor or ARB, plus a calcium channel blocker, plus a thiazide-like diuretic. And then step 4 depends. So the first question is what their potassium is. That's what the K plus stands for, it's potassium. If the potassium is over 4.5 millimoles, then we're going to use an alpha blocker. We can use a beta blocker, it's still in the guidelines, but they're not very good, so we tend to use an alpha blocker. If the potassium is under 4.5, then we're going to add a potassium sparing diuretic. The reason for this is because potassium sparing diuretics, as the name in English suggests, increase the potassium. So if it's already high, then these can be dangerous because it can elevate potassium to dangerous levels. It can start to cause heart arrhythmias, things like that. It's important to note that, as with any rule, decisions don't always follow these algorithms. They don't always follow these rules. And they can be based on medication availability, whether medications have been tolerated by the patient in terms of side effects, and what their other medical conditions are. So there's a degree of subtlety to these as well. Okay. So, pardon me. So moving on now, I'm just going to talk a little bit about what some of the side effects of these medications can be and what you have to be careful of when you're prescribing them. So for absolutely all antihypertensives, postural hypotension, so that's a drop in blood pressure when standing up that can cause loss of consciousness and falls, is a potential side effect, and an important one, particularly in the elderly, who can sustain quite serious damage if they fall from standing. ACE inhibitors and angiotensin receptor blockers, confusingly, can actually cause acute kidney injuries because they reduce the perfusion pressure of the kidney, even though in the long term, if they're tolerated, they tend to actually protect the kidneys. Calcium channel blockers can cause swelling of the ankles, which, while it isn't very serious, can often be quite distressing for patients and is a reason they stop taking it. Amlodipine particularly is notorious for it. And diuretics can cause electrolyte imbalances, which makes sense given that their mechanism of action is to manipulate electrolytes. There's also 2 important cautions with these drugs to be aware of that you should know in medical school. The first one is don't combine an ACE inhibitor and an angiotensin receptor blocker. It's not the end of the world if you do, but it's no more effective than just using one of them, and it does increase the risk of side effects. And the other one is don't combine a beta blocker and a non-dihydropyridine calcium channel blocker. So those are the ones that work on the heart muscle and on the atrioventricular node. The reason is that both of these medications work on the atrioventricular node, and when given together, they can cause complete heart block. Okay, and then the last little bit I'm going to chat about is what we have to do for patients that isn't related to medications in order to improve their hypertension. So the classic one is diet. There's quite a few things in here. It contains well-established risk factors for hypertension. Salt intake, so salt restriction has been proven to reduce mortality, actually even in patients who aren't hypertensive. This goes for hypertension too. Alcohol reduction reduces hypertension. Caffeine reduction reduces hypertension. Exercise will generally improve cardiovascular health, and this goes for high blood pressure as well. It will help with that. Smoking cessation is important as well because the nicotine in cigarettes causes constriction of blood vessels, and so smoking makes hypertension worse. And it's important to discuss all these things with the patient in a very non-judgmental way and explore how you can help them improve their risk factors. Even if you can't make things perfect for the patient, you can usually help people to improve things. So, for example, to exercise a little bit more, to smoke a little less. And then finally, it's very important to follow these patients up. So they should have regular checkups to review their blood pressure, to make sure the medications are working and they're happy with any side effects they're getting. The exact frequency will, of course, vary by healthcare system and by the patient. Okay, so that actually brings us to the end of the talking portion of this presentation. Now I'm actually going to go on to just a few interactive cases, and as I understand it, I'm going to put the question up, and then anyone watching will be able to send in their answers. I'd encourage anyone watching at home, do this as if you were doing a practice test. So try and reason through, and we'll discuss each of the options afterwards. Okay. So our first question, just going back to that treatment algorithm I showed you, just thinking in terms of step 1, which of the following patients would be suitable for amlodipine? So that's one of the dihydropyridine calcium channel blockers as a first-line therapy. A 42-year-old black woman, a 32-year-old man, a 58-year-old woman with type 2 diabetes, or a 67-year-old man with chronic kidney disease and severe albuminuria. So that's a high albumin to creatinine ratio, as you mentioned earlier. And I'm just gonna wait a little while.
Yeah, I'm gonna say the question in Spanish, and then we're gonna let you get answers. Vamos a empezar con la parte interactiva, con los casos clínicos, considerando el algoritmo que el doctor mencionó. El primer caso clínico es una pregunta acerca de amlodipino. ¿Cuál de los siguientes pacientes sería un candidato para amlodipino como primera línea de terapia? A, una mujer de afrodescendencia de 42 años, un hombre de 32 años, una mujer de 58 años con diabetes mellitus tipo 2 o un hombre de 67 años con enfermedad renal crónica y albuminuria severa. Ahorita vamos a revisar todos los canales para ver qué respuestas tienen y vamos
Respuesta A, dicen. Gabo Mendoza. Respuesta A.
Okay. Tenemos, we have one answer. One person said A would be the answer. We're going to wait a little bit more for more answers.
Yeah, I'll wait a little while and then we'll discuss which one's correct, and I'll go through and say why the other ones aren't ideal.
Perfect. Another person said A. Gabo Mendoza, Alejandra